The advertising messages in this episode are brought to you by G1 Therapeutics Incorporated. Chemotherapy can damage bone marrow, specifically hematopoietic stem and progenitor cells, the source of all blood cell lineages. Learn more about the myelosuppressive effects of chemotherapy and an FDA-approved therapy at www.chemomyelosuppression.com. You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are joined by ONS member Susan Bruce, Clinical Nurse Specialist at Duke Cancer Center in Raleigh, North Carolina, and member of the North Carolina Triangle ONS chapter, to discuss management and prevention methods for febrile neutropenia. This episode is the second in a series about oncologic emergencies. The first is linked in the episode notes. The advertising messages in this episode are brought to you by G1 Therapeutics Incorporated. Thanks for joining us today, Susan.
Thanks, Stephanie. I'm happy to be here to talk to you about such an important topic.
Exactly. Oncologic emergencies are a very important topic for us to be discussing today. And I think oncology nurses really need to be aware of, understand, and know how to treat these emergencies, because there are several of them that oncology patients could experience during their treatment journey.
Exactly.
So to start us off, can you give us some background on febrile neutropenia? What is it? How does it present?
Okay, febrile neutropenia, as we know, is a serious complication from cytotoxic chemotherapy. It predisposes our patients with cancer to serious infection, and oncologic emergencies are associated with high rates of morbidity and mortality, and are reported to be as high as 58% in patients with multiple comorbidities. Fever is often the only clinical sign of an underlying infection when patients are neutropenic, and that neutropenic fever we define as a single oral temperature of 38.3 or 101 Fahrenheit or higher, or a temperature of 38 centigrade, 100.4 Fahrenheit or higher that is sustained for more than 1 hour. Patients often present with a fever, and it's not until we check their white blood cell counts and their ANC that we can confirm that they have febrile neutropenia. ANCs of 1,500 or less are considered neutropenia.
Thank you. That's a very, very good explanation of what it is and what nurses need to be looking for. Let's talk about the treatments that our oncology patients receive. Are there any treatment regimens that are commonly associated with febrile neutropenia?
Yes, there are. Our patients with solid tumors can have 10 to 15% chance of developing febrile neutropenia with their chemo regimens. And in our heme malignancy population, they can have as much as 80% that develop febrile neutropenia. A lot of that is with our high-dose regimens that we give to those patients, but we see it in standard regimens as well that contain drugs that we know cause febrile neutropenia. And we can also see it in myeloablative regimens that are used in preparation for stem cell transplants.
Well, that's a lot of our patient population, isn't it?
It sure is.
So speaking of patient populations, all of those regimens or diagnosis that you just kind of mentioned, are there any specific patient populations that may be at a greater risk for developing febrile neutropenia?
Yes, Stephanie, there are patients that have had febrile neutropenia in the past or at a greater risk for developing febrile neutropenia again, as are those patients that have been heavily treated with chemotherapy over the course of their trajectory.
It's good to know that there may be certain populations that we need to be more attuned to. Not that we would ever, not pay attention to any of our patients, but kind of that knowing that preemptive of, that might be a group that we really need to pay attention to and watch a little bit more closely. So are there any gero-oncology considerations?
I think our gero-oncology population in general tends to be more frail. They tend to have more comorbidities, and they can have impaired renal or hepatic function, which may impact the chemotherapy regimen that they receive. Some physicians may want to make dose reductions for these patients in an attempt to prevent febrile neutropenia from occurring. Age, comorbidities, the general overall well being should be considered when starting any chemotherapy regimen. And we should support these patients with growth factor if indicated by their chemotherapy regimen and the chance that they might become febrile neutropenic.
I'm sure with that particular patient population, as you mentioned, just history of comorbidities that they have, like you mentioned, and those things and their bone marrow just not really being as robust as their younger counterparts, patient counterparts, with getting their treatments, are going to really have febrile neutropenia be a higher risk for them. So let's talk about some of the nursing considerations with these patients. Can you talk about what are some of the most important nursing considerations with patients that have febrile neutropenia?
There's actually, and many people don't know this, whether they're in oncology or outside of oncology, but there is an international standard to administer IV antibiotics within 1 hour of onset of fever. This can be challenging in a community hospital that's very busy, like the one that I work at, where we have competing challenges such as strokes, people coming in with evolving MIs. We do know that a delay in time to antibiotic is also associated with a decrease in survival and a reported increase in mortality of about 7.6% for each hour of a delay. And that's pretty significant. And I've done some work with our emergency room on this, who was one of those groups of people that was unfamiliar with how to treat febrile neutropenia and didn't recognize the importance of treating it promptly. But I really got involved in this work with them. I had read 2 incident reports back to back where 2 heme malignancy patients of ours were in the emergency room and were delayed 8 hours before they received their antibiotic. And when I heard that, I said, that is just not acceptable. We need to do something about this. And pulled a group together to look at ways that we could improve this and improve the outcomes for our patients, because we know that they can get septic very quickly, and waiting 8 hours is a long time to wait when you possibly have an active infection going on. Also, at our facility, we use broad spectrum antibiotics, and we use monotherapy cefepime to treat our patients with febrile neutropenia. And then any additional antibiotics are added based on potential causes for infection. So that's how we tend to treat things. And I think those are some of the important considerations for nurses to be aware of.
Susan, that example that you gave is just heartbreaking for our patients. And yet at the same time, you bring up such a good point for our listeners who may be in community settings. as well as the reality of our patients being treated as outpatients on an outpatient basis. When we had the patients inpatient and we were doing our rounds and getting vitals on them every 4 hours, that's easier, let's say, to identify febrile neutropenia and get the treatment started very immediately and quickly for those patients versus when they might be at home and they think, they're not feeling good and, well, maybe, it's just a touch of the flu or, we're in a pandemic now. And so all of these different things that they have to think about and making sure that we as their oncology nurses get across to them how important this really is for their well-being and their outcome is just paramount for patients who are receiving treatment for a cancer diagnosis. And I really liked how you said that you worked with your emergency department to talk to them about the importance of fast tracking these patients. Some of our nurses that may be listening might be really blessed enough to be in a location that has an oncology emergency department, that strictly oncology patients go to. But there are so many of our patients that are, like you mentioned, in community sites that are going into just local community hospitals. And, the importance of us talking with our colleagues and making them aware of why, this is an important issue to treat quickly, and also in educating our patients to know the things to say when they go in, that, they are a cancer patient, when they had their treatment and things like that.
One of the things I'll go on to say that resulted from this work with the emergency room is the development of a fever card. And we give this fever card to all patients that receive chemotherapy, and we tell them, regardless of the time you develop that fever, you need to call your doctor. It doesn't matter if it's 3 a.m. and he's sleeping. You need to call him. He will decide if you're in that 7 to 10 day window for febrile neutropenia to occur, and he will direct you what the next steps are. And if that is going to the emergency room, you take that fever card and you present it to the person at registration that registers you. And that tells them that you need to be expedited to triage right away to get this process started, because we are on a time crunch, so to speak, with that 1 hour window.
That's a great idea. And I'm sure something that, a lot of people listening might want to institute something like that if they haven't already. Great idea.
The idea originally came about because not all of our patients live locally. Some live several hours away from our emergency department. And while we'd rather have them come to our department, the reality is the physician may say, go to your closest local emergency room. And the card was really developed for presenting that card to outside local emergency rooms that may not see much of febrile neutropenia or treat much of it. So on the card, it gives what the workup is for febrile neutropenia, what the antibiotic choice is, and explains why this is a current cancer emergency for the patient. So that was the impetus that got us working on the fever card. And then when I worked with the emergency room, it just made sense to roll it out there as well.
So now that we've talked about treatments that are associated with it and our populations that are at risk, are there any strategies for preventing febrile neutropenia from developing in the first place?
Yes, if we know that patient's been heavily pretreated or has had febrile neutropenia in the past, The oncologist may want to make a dose reduction, but that's not really preferred for patients that present with curative intent and we have the opportunity to cure their cancer. We want to keep those patients on schedule as much as possible. So, given that, we will offer growth factor support 24 hours after chemotherapy has been completed. And that's in the form of Neulasta, the Neulasta on-body injector, or some of the generic growth factors like Udenyca, which we use at our facility.
Well, thank you. I think that those are really good points. And it really is important to, like you said, be preemptive and hopefully keep those patients on track with their treatment so that they can have the best outcome possible. So you mentioned a little bit when you were talking about your fever card, the workup process. Can you talk about what that is for a patient who has a suspected febrile neutropenia?
Sure. When they present to the emergency room, they get triaged, and then from that process, they start getting labs, a complete blood cell count with differential so we can check their ANC. They get 2 blood cultures, 2 sets. They'll get a urine CNS, and a chest x-ray. If there is other signs and symptoms, such as maybe their porticast site is tender, we may swab that or do a culture if there's any drainage present, or we just look at other potential signs and symptoms of infection and things that we may need to do to treat those, whether it's adding an additional antibiotic to the cefepime or just being alert to those signs and symptoms.
The advertising messages in this episode are brought to you by G1 Therapeutics Incorporated. There's a way to help protect hematopoietic stem and progenitor cells in the bone marrow against the harmful effects of chemotherapy. To learn more about an FDA-approved therapy, visit www.chemomyelosuppression.com. So Susan, you talked about your fever card that you all developed and working with the nurses in oncology as well as working with the emergency department on understanding that and where to kind of fast track those patients. Are there any other nurse-driven protocols for management of febrile neutropenia that you would say has been put in place to ensure timely assessment and interventions?
Not particularly at our facility, but I've read some articles and in researching this topic, some places actually administer the antibiotic after the lab work and the blood cultures are done so as not to miss that 1 hour window of opportunity. And that was something that we talked about in the very beginning with our work that we did. But we were making some headway with getting the antibiotic administered within an hour or less. So we abandoned that thought, and we currently are not doing that. But there are some facilities that do that. And the advantage of that is you don't miss the 1 hour time window. The disadvantage is if the patient's not febrile neutropenic, at that time, they've gotten an antibiotic that they didn't need. So you kind of have to weigh the benefit and the advantage of doing that.
So, the ONS communities is somewhere that ONS members can, post questions and, find out from their colleagues across the country, what some of the best practices are, or, we're having this issue in our institution. Is anybody else having something like this? And there was a discussion thread that I wanted to ask you about. So the discussion was over the best workflow for patients who present with a fever in an outpatient cancer center during the COVID-19 coronavirus pandemic. So for some centers, anyone with a fever may be an exposure risk. So what are some workflow options for nurses in this scenario?
We start out by checking labs and any symptoms to determine if there is a risk that the patient might be have febrile neutropenia, and we would get those labs and blood cultures to get started. If their labs came back and they were not febrile neutropenic, we would do COVID testing to determine if the patient had COVID. And if they had COVID, they would either go to the emergency room or get admitted directly to our COVID unit.
Thank you. I think a lot of nurses are, questioning how to do this. What is the best practice in this situation? And it's just such an important thing and also so stressful at the same time. Not only is it an onc emergency, but it's also during a pandemic. So, wanting to keep our patients as safe as possible as we can. So now I would like to ask you, kind of turn to a different topic, and let's talk about educating patients. How do you recommend oncology nurses educate their patients on febrile neutropenia during their treatment?
This is something that I think we really need to stress with our patients and their caregivers, the importance of reporting a fever, especially when they're receiving chemotherapy, and as soon as possible, and let the physician determine if that's in the 7 to 10 to 14 day window when febrile neutropenia can occur. With the development of the fever card, as I said earlier, we just give that to every patient and review it with them and just continue to stress how important this is, that this is an emergency to them. It can be life-threatening. We don't want to scare them when we say that to them, but we have to make them understand that this is a life-threatening complication for you, and we need to act very quickly on this information. So having them call their doctor, who will then further assess and direct them on next steps, I think is the best thing that we can do. And then if they do go to the emergency, once they're in the emergency room, they show the card at registration to get expedited and get treatment started as soon as possible. So we really stress that information with our patients. And we have those cards in the cancer center. We have them in the hospital. So our patients that are admitted inpatient for their chemotherapy, we make sure they have one of those fever cards prior to discharge, and again, review the importance and stress the importance with them.
Thank you. I think going back to the card you guys made, which I think is a great idea, but our patients have so much information coming at them, and to have something tangible in their hand to take and be able to put on the refrigerator or share with their family members, loved one, caregivers, just the importance of that as they're trying to remember everything that we tell them. So that really has to be so helpful and just reassuring to them that they have something to look at, and they know they don't have to question or worry, like you said, at 3 a.m. that they recognize that they have a fever. It is absolutely imperative that they call, and it doesn't matter. You're not waking somebody up. It doesn't matter. That doesn't, that's not the issue. The issue is making sure that you're taken care of and that you're notifying the team if something is going wrong. Susan, you have just given us so much information, and all of the tips that you've given us, and talking about your fever card and how you've worked with your emergency department has just been incredible. And I know that our listeners are going to appreciate all of that information as well. And as we finish up today, there are a few questions that I always finish our podcast with, and we're going to go quick fire on these questions. And the first one that I have for you is, what are common misconceptions about febrile neutropenia?
So for people outside of oncology, they often lack the understanding and of the importance of having a fever when you're a cancer patient receiving treatment. and lack the understanding of how sick and how quickly this can occur for a patient if they don't receive prompt intervention. So I think that's why it's important to work with anybody that's going to have access to your patients. And our biggest goal is to keep our oncology patients out of the emergency room by whatever means possible. If that means when they come into our clinic and are found to be neutropenic, we start the workup there and get the antibiotic in and get them direct admitted to the hospital. So just trying to avoid the emergency room because we know bad things can happen there for our patients. They're exposed with all types of people with coughs, colds, sneezing, whatever, you name it. And we don't know what those other patients have. So it's a particular risk for them. We also have a symptom management clinic on the weekend so that any patient that calls their physician on the weekend and maybe febrile neutropenic can get an appointment in the symptom management clinic to receive their antibiotic and then be admitted to the hospital. So I think those are important things and a couple misconceptions about the importance of febrile neutropenia.
Next, what is something about febrile neutropenia that's not often discussed, but you wish more people knew about?
So I have to go back to those guidelines, those febrile neutropenia guidelines that have been endorsed by the American Society of Clinical Oncology, as well as the Surviving Sepsis campaign. I'm not sure everyone is aware of the guidelines, even nurses within oncology. And unless you bring a lot of attention to that, they don't know that. And the time to administration is such a key piece of the guidelines and can really impact patient outcomes. So it's just so important that they know about this and know that this needs to be taken seriously. And we need to react in the best outcome for our patients.
And now, what about additional training or education for oncology nurses to understand and manage febrile neutropenia?
So I think we all have to look at this particular point in time where we have a massive nursing shortage, and a lot of us are hiring new grads, which we wouldn't have normally done, possibly, or we have new to oncology nurses that come to us from other areas of the hospital. I cover 2 inpatient units, and I try to repeat educational in-services every quarter to catch new people coming in, just to stress the importance of febrile neutropenia and how to react to it. I like to use real patient case studies that have occurred to help emphasize the importance of febrile neutropenia. I have referred to those 2 incident reports of patients waiting for over 8 hours as, one of the strategies to really drive home the importance of getting these patients treated promptly. But I think we have to keep up with the continuous education as our new grads and our new to oncology nurses come into our work settings.
I can't agree with you more. I think that that's such an important thing for them to learn and understand. And like I said, there's not only for patients is there a lot to learn and to remember, when they're being educated about their treatment and what they have to expect. But our oncology nurses have so many things coming at them, all of the new treatments that are out there almost daily, or at least several month new treatments that are coming out for patients, for nurses to understand and learn about biomarkers and all the testing that's happening. There are so many different things. And so for nurses that are new to oncology, it is a lot, but these oncologic emergencies that they may, experience with their patients are just as important as all of those other things. And so that education is really, really an important piece.
Yeah, I think it's really foundational to the care of our patients. And that's why I try and focus a lot on febrile neutropenia and some of the other oncologic emergencies as well. because they are and can be life-threatening to our patients.
Absolutely. Susan, thank you so much for being with us today. This has been extremely informative, and I know that our listeners will really appreciate the information that you've provided for us today. Do you have any final comments for us?
I like to say that nurses are often the last line of defense for our patients and for their safety. It depends on us. So we need to be well versed on oncologic emergencies, not just febrile neutropenia, as these events can be very life-threatening for our patients and impact their overall outcome. So we are their advocate, and it's up to us to speak up. And if you're in an inpatient setting and you've paged the doctor and have notified them that the patient has a fever and the doctor hasn't responded appropriately by giving you orders and an antibiotic order, I think it's on you to call them back. And my style is I'll page you every 5 minutes if I have to get what I need for that patient. So I think we all have to just be very excellent advocates for our patient and know what the right thing to do is.
I agree with you. Thank you so much, Susan, for being with us today. I really appreciate it and appreciate your expertise and knowledge in this area.
Thank you, Stephanie. It's been a real pleasure to talk with you again.
The advertising messages in this episode were brought to you by G1 Therapeutics, Incorporated. Learn more about protecting the bone marrow, the source of all blood cell lineages, from the damaging effects of chemotherapy at www.chemomyelosuppression.com. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.